So does it mean that when you have the family, these are the most powerful
Good afternoon, everyone. Thank you for joining. I think we'll give a few minutes for other people to join, and then we can proceed. I think we can now start, and then the rest will join as we proceed. So, hi everyone, and warm welcome to this webinar. What is health financing, and how does it affect Kenya? And how does Kenya finance its health system? Why the shift to SHIF, and what are the implications? My name is Linnea Mbai, the Communications and the Public Engagement Officer here at KEMRI-Wellcome Trust Program, and I'm in charge of this university engagement. Over the years, we have engaged young people from different institutions on a wide array of health and health-related dialogues. The main purpose for such an engagement is just to enhance the understanding of health, of research, empowering the next generation of African researchers, while also encouraging dialogue among the university students in Kenya. Today's webinar will be facilitated by Robinson Oyando, who is a PhD fellow under the Health Economics Research Unit, HERU, here at KEMRI-Wellcome Trust, and Zilper Audi, a PhD fellow from the London School of Economics and Political Science. So before we start, I'd like to just mention a few housekeeping rules, and then we can proceed. So this webinar will be recorded for it to be uploaded later on our YouTube platform, and then you can rewatch it whenever you need. And then also, please, if you have any question while the presenters are going on, please, you can leave them here at the chat box. Then my colleague Lavender will help take note of them and ask the questions later. And then we'll only have a few slots open for people to directly ask questions to the presenter. So if your internet is stable, please, you can raise your hand, and then we will unmute you to ask your question. So thank you for that, and over to you, Robinson and Zilper.
Thanks very much, Linnea, and thanks everyone for finding time to attend today's webinar. I'll just be uploading the presentation shortly, and perhaps someone can help confirm if it's visible.
Yes, it is.
Okay, I'll have it on presentation mode. Okay, thanks very much. So this afternoon, I'm just going to spend a couple of minutes speaking, I think, about one thing that I find very interesting to me, and of course, it's also part of what I do at the KEMRI-Wellcome Trust research program. So, of course, as Linnea has outlined, and even as it was indicated in the poster for this webinar, I just want to briefly unpack what health financing is in this talk, and some of the ongoing changes around how the government is financing the health system of Kenya. So I'll take the first session, then my colleague Zilper will pick up from where I've left. So I think I'll proceed. So when you hear of the word health financing, I know it may be new to some of us, but not very new to others. But in really very basic terms, this is health financing basically entails how financial resources are mobilized and put to use so that every person who has healthcare need can be able to access healthcare services that are of quality. You may have heard of the term universal health coverage, which is a global priority included actually in the Sustainable Development Goals. And UHC, for those who may not know what that means, universal health coverage is really about aiming at ensuring that people are able to access the healthcare services that they need. This could be preventive services, promotive, curative, rehabilitative, whatsoever health need that somebody may have, without, number one, suffering financial hardship, and of course also ensuring that the health services that they access are of quality. So then I think it's how countries finance the health system is actually a pillar to then how countries progress towards universal health coverage. So when we talk of health financing, there are normally three main functions. I'll just mention it in brief, then I'll give a bit more detail in the next couple of slides. So we talk of this resource mobilization, which is the first health financing function. Briefly, this is just around, what mechanisms have countries put in place to raise revenue or resources for the health sector. Then there's pooling, which pooling basically means of healthcare risks as well as healthcare resources. And as I've mentioned, I'll delve this deeply into this in the next couple of slides. Then there's purchasing. Now, once we've mobilized the resources, we've brought them into one common pool or one basket. How are these funds used to ensure that healthcare services are delivered by providers? So work that has been done largely by the WHO, including World Bank, has shown that for countries to progress towards universal health coverage, there's need to strengthen countries' health system, including health financing reforms, are part of that particular is one of the particular changes that actually should be made if countries are to progress and attain UHC. So as I mentioned in the previous slide, when we talk of health, of revenue, of resource or revenue mobilization in health financing, this it's recommended that revenue should be mobilized in a way that people don't suffer catastrophic or huge cost burdens as a result of accessing healthcare. So you may know that sometimes when somebody is ill and they want to, they think of going to the hospital, one of the factors that could actually act as a barrier is asking themselves whether they even have the money to be able to pay for that particular service that they're going to get. So what affects that depends with how much the government has raised and has allocated to the health sector of a particular country, say, for example, Kenya. Then when we talk of risk pooling, the ideal is that we want to reduce fragmentation. This is what I would call I think just for simple illustration, a chama. When we have several people bringing in their money and we're having one common pool, which will contain people who are wealthy, people who are not wealthy. So there's always something called income and risk cross-subsidization. So if that's the principle really around health insurance, that when people pool their funds together, there are people within that pool who will contribute, but they won't necessarily be ill. So then they'll be able to cover those who are ill. Then also the other bit of cross-subsidization is around the income. The pool will contain people of multiple socioeconomic status. The people who will be wealthier than the others, and hence, as a result, those who are wealthy will be able to cover those who are less wealthy. So that's what should happen in an ideal health financing situation. Then lastly, there's healthcare purchasing. So the way we reimburse or we compensate various healthcare providers for the services that they provide. So the requirement here is that the purchasing of healthcare services should be strategic, and and when purchasing the various purchasing mechanisms that perhaps we may not cover through this webinar, but essentially when providers are being compensated or reimbursed for the services they've provided to the population, an ideal health purchasing arrangement should ensure that quality, efficiency, equity, and responsiveness to actually the population healthcare needs are actually adhered to. So I think those are some of the three things that will influence rather whether a country is actually attaining its health financing goals as outlined in the Sustainable Development Goals or otherwise. So when we come particularly to resource mobilization, what are the main issues here? So, for example, in Kenya, how do we finance our health system? how do we finance our health system, and how is even how this money is being collected, and who collects these monies. So in principle, it's a rule of thumb, or rather for countries that have shown significant progress towards UHC, it's recommended that the main financing option should be from the government revenues. So that's what we've highlighted there. It should come from general revenues, though also these other sources, for example, development assistance for health, what multinational or bilateral donor agencies could give to support the provision of healthcare services. There's also situations where we have health insurance cover. I know a majority of us are familiar with NHIF, which was mandatory for people who are in the formal sector. So basically, people can also contribute or raise revenue for the health sector through mandatory contributions. Then others also include voluntary health insurance premiums, and I think NHIF, among the reforms that they made over time, I think perhaps in 2015, was to also include people from the informal sector, because right from its inception, it was just covering formal sector people. But I think Zilper will speak more to that. Then there are also, of course, philanthropy or donations. Then the last option of raising revenue is out-of-pocket payments, which evidence has shown that it's regressive. Regressive to mean that the poorer individuals or households tend to contribute a higher share of their income in terms of meeting healthcare needs, and unlike those who are wealthier. So still on the sources of funding for health in Kenya, and I'll perhaps provide some indicators to this in the next couple of slides. So general revenues, these are mainly from government, and this can be either from taxes, which can be direct or indirect, and also just other revenue sources that the government raises from its enterprises. So this basket of money is what the government uses to allocate then to health, and of course to also other sectors, education, water, and what have you. So when we talk of mandatory contributions, as I mentioned earlier on, it was mandatory, and it's still even mandatory in the current reform, that people in the formal sector are deducted from their payroll to contribute towards the social health insurance system. Then voluntary insurance premium, this can either be private or community-based. When you hear of the BRITAMs, the Jubilee, people also have the autonomy to subscribe to these forms of health insurance coverage. Then in terms of development assistance for health, I think these have really played a key role around ensuring that the parallel programs like HIV or malaria or TB are they've prioritized that. The donor community have really over time really allocated a huge share of their resources towards supporting such parallel programs. So, and when we talk of out-of-pocket payments, like that I mentioned, is regressive. There's overwhelming evidence, not only in Kenya, but also across other countries in the African region, for instance, that when people pay out of pocket, they tend to, they could be pushed further to poverty, or they could have to forego other things like, for example, education, food, shelter, and what have you. So in simple terms, what I'm just trying to emphasize here is that when we talk of how a country should finance its health system, then out-of-pocket payments should really not be a policy option, or should not really be the case. And fortunately, that's normally what the case is for most countries, including Kenya. And there's a school of thought that really tries to emphasize that if Kenya and other countries are to progress towards universal health coverage, then the bulk or the huge share of revenue should come from the government, that is the taxes. So when we talk of pooling, what are the main concerns around pooling of funds? This is how can we make household spending on healthcare more predictable. You know, the idea of pooling is that you contribute to a given pool, not necessarily because you are sick, but just so that we have a huge pot of money that can be used by a purchaser to purchase healthcare services on behalf of the population. Then also the other issues of concern when it comes to pooling of resources is around how we can protect households from having to pay the full cost of care out of pocket in the illness event. So if as a country we had adequate and efficient pooling mechanisms when it comes to financing our health system, this is what should happen in ideal. And again, it's really about risk pooling, as I mentioned, around income as well as risks. So the healthy people help the sick people within that pool to be able to meet their healthcare needs, as well as the rich would help or subsidize the poor when it comes to accessing healthcare services. And if that is to happen, then the resultant effect will be increased financial protection, where we have a big pool that contains a myriad and characteristics of either poor or wealthy or sick and healthy people. So this is what should happen in ideal, but there's evidence that, for example, even in the NHIF that was just phased out sometime last year, that was not the case. There were very many multiple pools that was leading to inefficiencies, inequities, in terms of access to care. So the challenge around, if people only, for example, in the informal sector, when we talk of, informal people or informal sector people subscribing to a health insurance cover, in most cases, it will only happen that they will do this as a result of an illness event, not as a result of just being cautious of the need for pooling resources and the benefits of such. So there's a term known as adverse selection, where we know that if there are no policies and structure in place to ensure that the country mobilizes revenue, in a mandatory fashion, then when people are left to contribute towards the pool voluntarily, we'll have the negative effect of adverse selection. So when we talk of now the last health financing, or rather last health financing function, which is purchasing, this is using the pooled resources to pay for healthcare providers on behalf of the population. So the main concerns around purchasing basically include who purchases on behalf of whom. So depending on who is in the composition of people in the risk pool, then it will enable the cross subsidization that I was speaking about earlier on. Then what services are we purchasing? So there's need to have a clearly defined benefits package that says, for example, that in Kenya, given our disease burden in the population, these are the core set of healthcare services that we are going to purchase on behalf of the population. And of course, the benefit package also needs to be broad so that a good number of conditions are covered. Then purchasing from whom? Are we going to purchase entirely from the public providers, or we are going to purchase from private providers, or a mix of that? So those are some of the issues that when we are designing our purchasing arrangements, we need to actually put into consideration. Then how are we going to purchase? How are we going to, reimburse these providers? Perhaps if I may just mention one of the purchasing arrangements that is normally there, county government will have, for example, say line item budgets. We want to allocate this much of the health funds to health products and technologies. We want to allocate this much to paying the salaries of healthcare workers. We want to allocate this much towards constructing more healthcare facilities. So there are various incentives that and provider behavior that can be observed as a result of the purchasing arrangement that has been implemented by a country. So I think the important thing to note here again is that given that resources and capacity are limited, of course, not everything can be covered. We can't cover all the health conditions out there that the population may be suffering from, but now given the disease burden or the epidemiological landscape of a country, choices will be made on what needs to be covered, how cost effective are these interventions, and so on and so forth. So I think the bottom line here is that when purchasing healthcare services, countries need to come up with a clearly defined benefit package that is fair and is representative of the true disease burden in the population. So I think I'll request Zilper to pick it up from here on health insurance status in Kenya, and how has the journey been since this was begun pre-independence period or post-independent period. Over to you, Zilper. Thanks.
Thank you, Robinson. Hi, everyone. And as Robinson and Linia mentioned, I am a PhD fellow in health economics and London School of Economics. And I'll just pick up from where Robinson was left. And like he's mentioned previously, one of the risk pooling mechanisms that Kenya uses is the social health insurance or contribution that are mandatory. And so when you look at health insurance in Kenya, our approach to UHC is through the use of health insurance mechanism. And here we have NHIF, or currently SHI, as the preferred vehicle for this move towards UHC. And just a quick background about NHIF. This was established in 1966. And initially it was meant to cover the formal sector employees. And over the years, it has expanded to cover those in the informal sector. And the benefits also have been expanded over the years. And this has seen us move away from covering only inpatient cases to now also covering outpatient cases. We've also seen that there's been an expanded benefits package that was introduced to cover even more specialized services. Next slide. Yes, and so despite, and there have been lots of reforms over the years, I mean, it's been quite a while. Despite these reforms, we see that less than 26% of Kenyans are currently covered by any health insurance. That is 1 in 4 people. This was the latest report by the Kenya Demographic Health Survey in 2022. And of this number, 24% of those covered were in the NHIF, and only 2% were covered by private health insurances. And it's key to note that it's been 58 years since NHIF was founded, and only a quarter of Kenyan people are covered by any type of health insurance. So we see that NHIF has had very low coverage. It's been a big struggle that it has faced over the years. And of course, as we say, this then goes against the achievement of UHC, because if you want people to be fully covered, for them not to face any impoverishing or catastrophic health needs when accessing healthcare, then we must find ways to improve our healthcare coverage. Next slide. Robin took us through the initial Kenya's health financing model. And if you look at the NHIF, for instance, we see that it faces a number of inefficiencies, one of them being in terms of the way it raises its revenues. So like we've mentioned, although it's the biggest health insurance mechanism currently, the NHIF, or I'll keep saying NHIF, but of course we know it's moved now to SHA. We still have people mostly in the informal sector who remain uninsured. And this means that there's also quite a bit of out-of-pocket payments that people tend to make, I think over 30% of expenditures goes to OOPs, and this then contributes to financial hardships. And if you can be both financial hardship in the sense of being catastrophic or impoverishing, if you have to sell something to access healthcare, if you have to forego something, if you have to forego your meals to access healthcare, then that will not help us achieve universal health coverage. Something else about the NHIF in general, and also the way we finance our health model, is that access to healthcare has remained unequal. And so if you live in a place like Nairobi, you often have access to a health facility, but those in remote areas in far-flung counties often don't have access to healthcare facilities, or they have to walk quite a bit to access the healthcare facilities. And in some cases, even if they access those facilities, then they don't find services. There's no doctor or clinical officer, there's no medicine, and then they're forced to go to a private facility and also spend out-of-pocket expenses. Yes, next slide, please. And so when we look at health expenditure, this tells about the health expenditure indicators in Kenya. And if you look how over the years, there has been a change. So the green is total health expenditure per capita, sorry, the blue rather. And you can see how it has grown over the years from 2001 being just around 7.9%, about $60 billion. And currently we are at around over 100, is it billion?
It's 105 per capita per person. So basically,
okay.
Yeah.
Okay. And then the red is the percentage of health expenditures as a percentage of GDP. And we see this has been moving just between 5%, and the highest being 2012, where it was at 7%. But you can tell that we are just navigating around 5 to 6% thereabout. And that means that these need to actually increase the amount of money we are putting in terms of health expenditures as a percentage of our GDP. And government expenditures as a percentage of total government expenditure. So government health expenditure, we see it's risen. It fell down in between 0.5 to 0.9, but it's risen over the years. Currently, we're at about 11.7%. Of course, this data is not the latest data, but this is what we are trying to work around. Next slide, please. And so with regards to health financing, we see that different governments over the years have tried to make efforts to reform healthcare. And of course, this follows their broad commitment to UHC and to ensure people have access for all. And so they've tried to make different reform attempts, and mostly targeting the NHIF. And some of these include the revision of premiums contributions in 2015. There's been the expansion of the benefits package, which previously was only covering inpatient care, but now covers also outpatient and also specialized care, for example, dialysis and other things like that, including also even taking people abroad to access specialized cancer treatment. And also there was a reform around the ICT system to automate different functions like claims management and premium payments. And we've seen different amendments to the NHIF Act. I think the last one was in 2022 before Uhuru left power. And then, of course, the latest one now being the Social Health Insurance Act that was passed last year towards the end of the year. But despite these reforms, the NHIF still struggles quite a bit with regards to the coverage, which remains very limited. And there are quite a bit of inefficiencies at the NHIF. Again, pardon me, I mean the same thing, NHIF structure. Of course, there are lots of governance challenges and concerns about financial sustainability challenges. And in some cases, even the NHIF was perceived to be not well suited or a bit ill-equipped to support Kenya's goal towards achieving universal health coverage. Next slide. So some of these challenges, I just highlight them, but these have been indicated in a report which I'd suggest everyone kindly have a look at, the HERU report. I don't know if Linia has it, she can maybe post it there and share with other people, but I think it's publicly available. So these were experts who came together to analyze challenges that the NHIF is facing. And they were able to have a very long report that was able to highlight these challenges and try to provide solutions that could then be used to address those challenges. One of the questions or the challenges that NHIF was facing was the lengthy and cumbersome process of empaneling facilities, and the fact that it always was biased towards either the private sector facilities, larger facilities, and also urban areas. And then there was inefficient contracting process. And so this means that the NHIF in many cases was unable to contract, let's say some facilities have networks. So I don't know, let's say Aga Khan, for example. Aga Khan has there's the main Aga Khan, but then there are also satellite Aga Khans in different areas. Those then are networks. So if you are going to contract Aga Khan, then it means like you also have to work together with those other network facilities. And of course, in context that in rural areas where they have smaller facilities, it becomes difficult then to have them contracted with the NHIF. Then also there was a question about the weak referral system. So in this case, then patients would be forced to bypass lower level facilities and go to, say, for example, Kenyatta with a migraine or with just with a headache or, just a bit of bleeding. And then this means that they're accessing high level facilities, which then tends to be more expensive. And by doing this, then it means like experts in those facilities have to have to address the challenges these guys are facing, while they could have been doing other things, which are also even more serious problems, which often happen in those higher level referral systems or facilities. And then there was also inadequate quality assurance mechanisms of trying to see like how are these facilities operating and are they providing quality services. There was also the issue about inadequate provider payment mechanisms. And in this case, the report found that NHIF was mostly a passive purchaser. And this is because to purchase in a manner that is strategic, then you have to have access to data. You have to try to balance and look at different, the cost of different interventions you're going to be offering and see, does this facility meet those objectives? What are the best ways for us to ensure we're getting value for money for the services we're going to be delivering? And then, of course, this is a big challenge that even most Kenyans have seen is about the weak complaints and feedback mechanism. Often it's not easy to get any feedback from the NHIF, even with the population ourselves, but also, I guess, with the facilities getting feedback from the Social Health Authority or the NHIF. And this lack of financial sustainability, this is a big issue because as people have increased or have become more at the NHIF, and as they expanded the benefits, we saw that they only increased quite a little bit of the premiums, and therefore the benefits payout, what people were getting, outpaced the amount of money they're contributing over the years, and therefore in this case the NHIF wouldn't have been sustainable. Another challenge was there were too many fragmented pools. As Robin has mentioned, if you want to ensure efficiencies, you don't want to have too much fragmentation. How then can we pull all these risks together? Because we want to ensure that we have that the rich and the poor, the sick and the healthy. We want to have the young and the old. But then in these cases, we have different pools. For example, civil servants are there. We have parastatals there. We have Linda Mama separately. We have Edu Afia, the health insurance subsidy program. So it's difficult to manage these pools. But also, many of these things, if a woman is pregnant, perhaps she'll use Linda Mama, but what if she's in civil servant as well? So all this then becomes a bit confusing and quite inefficient in a way. And then, of course, there have been issues around integrity and accountability questions. So this would be issues raised around fraud at the NHIF, but also at the facility level, which actually then tends to be quite big. And since the NHIF didn't have a way to really monitor the amount of claims being given to them, then it's very easy to pay out even without understanding whether the treatment really occurred or not. And then, of course, we've talked about the inadequate provider payment mechanisms, which then would lead to not getting the best value for money. Next slide, please. And so in 2023, the government adopted 4 UHC laws. The first one was the Primary Healthcare Act. The second one was Social Health Insurance Act. The third was Digital Health Act and a Facility Improvement Fund Act. All these acts go together. However, our concern for today is around Social Health Insurance Act. And this act establishes a new social health insurance agency. So basically, NHIF then became defunct as soon as SHI Act was adopted, and then Social Health Authority Authority then became the body that then manages what previously was NHIF rather. The difference between NHIF and social health insurance is while social health NHIF only had one fund, pretty much the contributory mechanism, SHI has 3 different funds. So it introduced 3 funds: the Primary Healthcare Fund, which funds level 2 and 3, the Social Health Insurance Fund that funds level 4 to 6, and then the Emergency, Chronic and Critical Illness Fund, which funds these conditions once we deplete the PHC and SHI funds. The big question, however, is that one has to be enrolled to access these funds, which I think is one of the issues that was in court. I don't know how that went about. But then this also is an issue that then goes against Article 43 of the Constitution about right to health. Next slide, please. Okay, so just very quickly, the goal of SHI, or Social Health Insurance Fund, basically is to ensure that every Kenyan, whether they're employed or not, is able to access healthcare services. This, I think, being the part of the UHC goal. And then this should be able to improve risk pooling, reduce out-of-pocket payments, and ensure that we have a more defined benefits package that covers a large or broad range of health services. So the changes that we saw are focusing on equity, and the aim here being to include marginalized groups. The aim also was to try and centralize health funds and improve how these funds are managed to reduce inefficiencies, and also to achieve broader coverage under the social health insurance framework. Next slide, thanks. So the way I was thinking about this is that in some sort of way, the SHI was trying to address some of the issues raised by the HERU report, or based on the challenges and assessment that was done by the experts who were able to draft the HERU report. And just very quickly, while the HERU report mentions issues around financial viability and the fact that the benefits, the payments had outpaced premiums, I think the idea here was to increase premiums. And another thing would be to adopt a tax-funded mechanism to ensure that there was more money than that comes into the SHI. That would be the Primary Healthcare Fund, emergency, let me just say ECCIF, as well as the contributions from members. And then the idea is also to reduce fragmentation. There are lots of pools. Actually, there are close to 75 different pools. And these pools then become very difficult to manage. And in order to address those inefficiencies, they felt it right then to harmonize these pools to reduce those inefficiencies. Maybe the question can be what they did with consultation with different people who are beneficiaries of those pools. And that's a different discussion, I guess. And then, of course, they wanted to address governance challenges. And And I think in this case, the issue would be especially around corruption. So I guess they thought like by separating tasks, for example, claims management, that they would be able to address some of those governance challenges. And so I guess like the claims management body would be able to ascertain and approve that the claims being made to the body, to SHA, then are legitimate and not falsified documents. They also aim to make enrollment mandatory. And I think in this issue, then they'd be able to reduce voluntary nature and adverse selection, where only people who are sick were registering to NHIF, because I think the assumption is like, if I've been paying insurance for the last 2 years, I didn't fall sick. So why should I pay? But we never know whether we'll fall sick today or next year, you know, so it's still good to be enrolled. But then that's the nature of humans anyway. The other thing is to strengthen referral mechanisms. One of the weaknesses that was mentioned by the HERU report was that NHIF had a very weak referral mechanism. And so I guess like by putting together the SHI Act, working together with the PHC Act, they wanted to strengthen the referral system so that people are able to start from the primary care level. And in that case, they have the primary care networks. And of course, the PHC Act also puts together the community health promoters. So like health, we need to begin looking at health right from the primary level before we get ourselves to Kenyatta Hospital, for example. So then here we see we get rid of, NHIF is defunct, and now we have SHI as the one operating. Next slide. This is very rough. So there's some very, a bit of differences here and there. So in terms of resource mobilization, we see that in both cases, we're still seeing contributions in NHIF and SHI. At the NHIF, premium contributions range from 500 shillings for those in the informal sector and 1,700 shillings for, up to an amount of money that people were earning. So I think after about, is it 100,000? I don't even know how much that was. You know, you are paying a flat rate of 1,700. So even if you're earning 2 million, you pay 1,700. That was very inequitable. But we see at SHI, we still have contributions from enrolled members, but then government has an allocation both for primary healthcare funds and the emergency, chronic and critical illness funds. It's one thing, however, to say that we have these funds or we'll be allocating X amount of money. But if you look at the previous budget, the initial allocation or the initial plan, the costing was supposed to be 50 billion shillings for the primary healthcare fund, another 50 billion for the ECCIF. However, what was allocated was much, much lower than that. So I think this is where citizens need to be more proactive and, ask those tough questions to the government, the right people. And then, of course, the good thing here, maybe to me, is that the premiums increased to address the challenges that about sustainability of the NHIF or SHI in this case. So then premiums become 2.5% of income. And then, so that means if you're earning 2 million, of course, you'll be paying more, but that is able to cross-subsidize for people who are poorer. And then it's also, there's the element of means testing, which wasn't there in the previous NHIF. And then the indigents, this is a good thing, the indigents, they will be paid for, their premiums will be paid for by the government. And I think the rate is 300 shillings for those people. The pooling in this case, we have both formal and informal sector employees. It was mandatory, but hard to enforce. SHI now says that pooling will be mandatory to all. The question is, how will they enforce this? For payment, you see here, the capitation at that point was 1,200 per person. However, this has been reduced in this current SHI. If you look at the current benefits package, it's been reduced to 900 shillings. So I guess they had good reasons why this was reduced. I don't know why. And then, of course, they could purchase from public, private, and non-profit providers. And like the HERU report noted, that the NHIF gave priority or a lot of leverage to the private providers. I guess Kenyans might also just want to go to private facilities because they know they will find the services there. But I think it's upon the government or NHIF and other bodies to ensure that the public facilities also are able to deliver services. And then the NHIF had quite a bit of broad benefits package that was, I think, improved over the years. And SHI also has an expanded benefits package. I kind of felt like it was broadened, but it wasn't deepened. So they're covering so many more things, but it wasn't deep enough, in my opinion. So, for example, I was looking at this with Robinson. Please correct me, Robinson. We look at dialysis, for example. While the NHIF would cover quite a number of sessions, the current SHI would cover, I think, 2 sessions. Is it Robinson? Would cover 2 sessions under SHI, and then 1 session under ECCIF. So 3 or 4 sessions is not adequate for someone who needs dialysis, generally speaking. Next page or next slide. So these are the implications of the shift from NHIF to SHI. So I say there would be a pro if well implemented. So I think that is, if it is well implemented, the fact that this new reform focuses on primary healthcare is really, really good and very important. The NHIF has been very hospital-centric. It focuses on going to hospitals and getting those expensive health services. However, social health insurance focuses on preventive care at the primary care level. So both from community health promoters and level 1 and 2, level 2 and 3 hospitals. So this in a way might lead to more prioritization of primary healthcare in the country, which then would be a good thing because it's much cheaper to provide primary care than provide those specialized care, tertiary care rather. And then it is mandatory in nature, which is a good thing because it would help address adverse selection, and it could, of course, help expand coverage to the previously uncovered people, especially in the informal sector, but also only if it's well implemented. And of course, the fact that it's covering emergencies and chronic illnesses is a really good thing because in many cases, the people who have accidents or some places can't even take them because they don't have health insurances. It also would help address the referral system weaknesses, which would be a good thing to ensure that specialist facilities are left to do specialist work, and other primary care level facilities then are able to take care of less serious cases. And it could also help lead to reduced out-of-pocket health expenditures. If people are covered by health insurance, then that should lead to reduced OOPs. You cannot completely get rid of out-of-pocket expenditures because, like Robinson mentioned, we have a benefits package which can't cover everything because we don't have unlimited resources. So only some things might be covered, but some you have to, I think, get them out of pocket. The fact that it's progressive in its contributory nature at 2.75%, I would say is good, at least in theory, because then wealthier people would pay more, and then this would subsidize for poorer people. And this solidarity nature, I think, is at the very core of social health insurance globally. And then this also means we might see increased resources through the tax-funded nature of from the primary healthcare fund and the emergency chronic and critical illness fund. So assuming the government had allocated 50 billion to PHC fund and 50 billion to ECCIF fund, all this would go to Social Health Authority. That's 100 billion. And then if you add to our contributions, that would be quite some good money that I think would really cover Kenyans really well. And also it limits administrative costs to just 5%. Next slide. However, there are cons, and I think these are things we really have to look at and maybe pay attention to when doing a registration for social health insurance or during our engagements with the different people in the health sector. So one of the things here is that there still remains the risk of corruption and mismanagement of funds, because then how are we going to ensure transparency and accountability in this, knowing our Kenya's system? This hasn't been well addressed, I think, with this new law that was passed. And in a way, it looks as if the this new law is a bit regressive. It has a regressive impact on low-income groups. So these people being made to pay, even if it's only 300 shillings, for somebody that's a lot of money. You know, they can't even afford that. So the government says they'll do a means testing. We don't know how that will be rolled out and how that will work, but looking forward to seeing how the engagements go ahead and how this actually will be implemented. But assuming that doesn't happen, then it means that the poorer people would still have to pay an X amount of money. That then can become, for them, even impoverishing or catastrophic in some cases. Then there's a big issue about supply side challenges. So we are very much concerned about getting the resources for the health sector here, for the social health authority or social health insurance. But the question is, as we're expanding insurance coverage to even more people, we want to move from 26% to, let's say, cover 70% of the population. We're not addressing issues around, you know, healthcare personnel and providers, issues around infrastructure, issues about equipment, you know. And so this means that people will continue going to those places they were going to before, leading to overcrowding. And in some cases, then there'll be an incentive for those providers to actually make people pay out-of-pocket payments. So I think this has to be addressed to successfully implement social health insurance. And the other bigger question here is, how then do they plan to enforce mandatory contribution in our informal economy? Kenya is largely informal, you know. We can barely know who to tax and how to tax them. And so it's not very clear how they plan to get money or how to make these people enroll. Of course, the plan was to say that you have to enroll to access healthcare services. But then, of course, is that really legitimate in law? So that's, I think, one of the questions that were being addressed by the court that was filed a few months ago. And then there's also a problem about having voluntary enrollment risks. So if you cannot enforce these mandatory mechanisms for, you know, enrollment, then it means like the informal sector might actually opt out. And then when they do that, then it leads to adverse selection. So only the sick people are going to enroll to a health insurance. And then we have discussions, and we've seen discussions at the Social Health Authority about outsourcing claims management to a third party. So while this, in a way, they say is meant to ensure that to address issues around fraud, it also introduces perverse incentives, because these perhaps are private interested groups, you know, and they would, you know, they would want to get the best out of that. And so I don't know how this is going to work in practice. And also, if they were reducing administrative costs to 5%, but they're still outsourcing, so really, are we making any savings there? How efficient is this? And then, of course, we know there are plans to employ means testing. I don't know how this is going to work, but also in practice, it can be quite costly and might cancel any gains that could be made. Next page, next slide, rather. So when you look at this transition, so it kind of looks like the system, I don't know, maybe things have changed the last few weeks, but the system still didn't seem ready for these changes. You know, we've seen the ongoing court cases, how prepared, for example, are the facilities at the primary care level. Like we've said, if you don't address some of these challenges, it means like sick people will continue going to the likes of Aga Khan and private health facilities. And therefore, are we ready even to implement the primary care networks? How far along have these gone? They're talking about putting together a digital health authority and you know, this superhighway working together. How far along has this gone? So it doesn't seem like this is clear. And it's almost 1 year since this law was adopted. So it's really good to, I'd be happy to hear any insights that any of you guys might be having. And then there are also issues around operational and logistical challenges. So implementing SHIF in nature might have some challenges in terms of data management, enrolling people, and processing claims, and of course, reaching the informal sector. And then the other issue is that we have our devolved governments who when I spoke to some of them, they mentioned that there wasn't much consultation in the design process of these new policies. And devolution in nature adds some complexity to this process because the counties are supposed to deliver the health services. And so the SHIF and SHA must work very closely with both national and the county government facilities to ensure smooth implementation. So the question is, are they working together in tandem with the county government, or how is this going about? And then there's a funding gap issue here. So to transition fully from NHIF to SHI would require some significant financial resources. Like we mentioned, the initial costing for PHC fund was 50 billion and ECCIF was 50 billion. However, the budget that was shared with us at least, I think PHC had about 4 billion allocated, and emergency chronic and critical illness fund had about 2.1 billion. So it's one thing to say we are committed to this, we've allocated X amount of money, or this is the costing, but then there's a funding issue here. Then the issue, another issue around here, we have the focus of the private sector facilities. So if you come from a rural area or you have small facilities where you live, we will still face the same challenges around empanelment, accreditation, and other things unless these things have been addressed. And I think maybe the discussion we can have here is like, I think most of us, even if you live in Nairobi or wherever you live in, you know, I guess many people still come from villages, and so your folks are still in the villages. And so if they fall sick, are they able to access quality healthcare services, or they will just have those level 2, 3 facilities that rarely have nurses or even medicine? So then that becomes a question, because then they either have to go to private health facilities and have to pay out-of-pocket healthcare payments. The concern that might actually be there, and this is just me, I don't think it's global, was the complete change really necessary? Like, you know, did we have to like completely get rid of NHIF and bring SHI? What exactly is the difference? You know, couldn't these issues have been addressed within the existing NHIF? But then that's just my own musing. So yeah, next slide, please. Oh yeah. So generally speaking, I would think that it's really good to see that the government of Kenya is prioritizing healthcare and health financing reform, and that is a good thing. And so I believe the transition should be able to be a critical step in Kenya's UHC journey. And if well implemented, I think SHI and can very greatly help address some of the challenges we've been facing around inefficiencies, around inequity in health financing, around many people not having any health insurance. I'm sure most of us have donations being asked of them each and every time, or some of us without health insurance, when you fall sick, you know, you have to ask other people, and it's really demoralizing, it's dehumanizing almost, you know. And so I believe if this is well implemented, I think it should be able to make some progress. But the biggest thing here is, and perhaps this is one of the things that the court case had, was lack of adequate, you know, public engagement, you know. So engaging with the healthcare providers, engaging with the public in general, engaging with the county governments. I think this is a big part of it, because this is a very big change, and it would be very good to ensure that everyone understands what changes are happening and how they can be involved. Yeah, so I think, I guess that's it. Next slide. I think that's it. Yeah, I think that's pretty much it. Yeah. Thanks.
Thank you so much, Robinson and Zilper, for the insightful presentation. This discussion has really deepened my understanding of the Kenya's health financing landscape and the implication of the shift to SHIF. It was very clear to see the pros and the cons of the shift, and that has really also helped me understand it even better. And it's also clear that this transition has far-fetching effects not only on policy, but also on how accessible and sustainable health services in Kenya can be. So now I would like to open the stage for questions. And Lavender, if you can take over. Okay, we can start with Kiptanui.
Thank you. First of all, let me thank you for the presentation and for this space to enhance the knowledge on health financing. So my question is, now that we have the basic information about the shift from NHIF to SHIF, so it begs the question that has this really been forwarded to the stakeholders in health, such that we can now be able to know whether we go on with the SHIF or not? Because if this research has been done and all this information has been brought out, then it should also push us to getting those basic information, such that when now this information is still in court, they of course they some of them know what has really happened, and so we also have to as well know the way forward. I don't know whether you've gotten what I've said. So that was just my concern, and yeah, thank you.
Robinson, do you want to take that, or should we wait for more questions? Maybe you can start with that as we wait for more questions.
Well, I don't know if I didn't get the clear what the question clearly was. Kindly, Kiptanu, if you can just kindly summarize yeah, kindly summarize so that I can give a response. Thanks. Or how do you want to go?
Okay. So I think Kiptanui wanted to know that, having presented all these, digital information about our financing and the shift from NHIF to SHIF, if this information has been forwarded to the stakeholders to know that to go on with SHIF, and if this information can still be able to reach, I think, in the cases where we have ongoing court cases, to add more information to this. It's a good question, Kiptanui. What Robinson, do you want to go? Do I go and then you come on? Yeah.
Yeah, perhaps let me try. I think sometime last year, you may remember the Cabinet Secretary for Health, Susan Nakumisha, was having these rounds in the counties in the name of public participation. So I think, as it is with government, whenever new rules or new policies are about to be implemented, for example, the transition from NHIF to SHIF, I think the approach is normally to kind of involve the broad range of stakeholders who might be affected by that particular policy change. So I think, to my knowledge, that's the only kind of public participation, or rather stakeholder involvement, that I witnessed throughout the transition phase. However, I think the court ruling, I've seen it publicly available in various platforms. Perhaps you may have also come across it. But I think one of the grievances that was being brought forward was the sort of hurried implementation of the transition from NHIF to SHIF. But just to kind of mention your question, rather to answer your question also, I think just the kind of public participation the MOH was trying to do last year. And of course, the policy making or policy change is always a political process. There are interests, that stakeholders who stand to gain by a policy change, and there are others who stand to lose. So in terms of stakeholder involvement or relaying this information on why this change, I think I can only relate to what the former cabinet secretary was trying to do at the various county levels. Thanks, and over.
And Kiptanui, if the question was also in regard to the current presentation, I would also say that most of these things, I guess, are in the public domain, and some of them have been raised in the court cases, which thankfully have been very instrumental in the court coming back to the ministry and asking them to, provide more justifications for a couple of things. But also, like we've talked about with regards to the HERU report, we can see that the social health insurance reform, in a way, was brought forward to address some of the existing challenges. So in general, I think it just didn't come out from nowhere. So there've been, like, over the years, different reform attempts that have then were able to coalesce into this larger reform that then was passed. Of course, the biggest issue, like Robinson has mentioned, was the nature that it was passed. They're very, very hurried, and they didn't necessarily follow all the legislative processes. So that, I think, becomes a big challenge. Yeah.
Okay, yeah. I think that's some crucial information that it's out there, and it all boils down to, we have a system that at times doesn't give space for public participation, so that we have all these questions to ask. And so because, for instance, I think we have already seen that SHIF has a lot of cons also, and it brings the question, why would NHIF been reorganized so that it can allow those? Because SHA will introduce some new things, but why not use NHIF also and improve the areas that we think are rather still not being addressed in the health system, and now rush into SHA? And as Robinson has said, it's true. Yeah, we have a lot of people with their own interests at hand, more than the masses, so that we have all these problems of interest and greed. So I think to thank also you for having forwarded and given out the information out there, and for reaching out to the public and informing them of all these changes in the health sector. And so we hope the courts will also take this, and it will put in some precautions when handling this matter, because the information is what is so important at this particular time, so that we have these things really digested in depth, and at the end of it, we find out some reasonable solution out of this. So thank you so much for this opportunity, and thank you guys for hosting this space, and God bless. Thank you.
Thank you, Kiptanui, for that question. Next, we'll take a question from Bikesh, who's asking why the Kenya government had a new SHI Act instead of amending the NHIF Act, and were there any provisions that really needed the new act?
Let me try.
Okay.
Let me try. I'm not looking for the government. I have no. Yeah. So I have spent the last 4 months doing my fieldwork and speaking to different policymakers to understand why this reform came about. And one of the things that came out clearly in these discussions was that there have been several amendments to the NHIF Act. Remember, we have the NHIF Act of 1966. And the latest act that has been implemented was the NHIF Act of 1998. And there was an attempt to amend NHIF Act in 2022 during the Uhuru time, which I think would have been a very good act, generally speaking. But that, even though it was passed in Parliament and signed into law by Uhuru, it was never implemented because, of course, of different private interests. So the question is, like, why did we need this new one? Why didn't you just amend existing NHIF? acts. The truth is we could have amended the existing NHIF Act. But my respondents mentioned to me that there have been lots of amendments and therefore they needed to have something new. But what I got from this was that when you have a new government, you need to show that you're doing something, you know, and just amending NHIF, even though it would have been useful, this allows them to bring many more things into one act. So I think that's why they were able to bring, for example, primary healthcare fund into this new act, and also the emergency chronic and critical illness fund into this. So I think this gave them leeway to add more things into the act, and then I think maybe expand coverage than they would have had to do with the previous amendments that they've been trying to do. So I think the main aim was that the other one had been over amended. So a new one was necessary this time around. Yeah.
Thank you for that. Zilper, we also still have another question for you from Joel, who's asking if you could comment on how the SHIS can solve the problem of limited access of this service, especially to the rural areas, having pinpointed that there was an imbalance before in the access of NHIF in rural and urban areas.
Yes, indeed. While we see from the HEFREP report that there has been a bias in the sense that NHIF has mostly covered facilities in urban settings, as well as those bigger level facilities. Yet majority of Kenyans live in rural areas. And so the question, like, how then do we get to them so that they're able to access healthcare services in the places where they live? The challenge here, though, is that we have both public and private health facilities. And so it cannot be an NHIF issue only or SHA issue only. They would have to work with the Ministry of Health and, of course, the counties as well. And so this, I think, is a broad-based issue. So I don't think the NHIF or SHA can do much except perhaps give terms or try to support these facilities to ensure that they are able to be get empaneled. But to do that, they need to work with different stakeholders. And I think county governments would need to play a key role there. But of course, in cases where they said there wasn't much consultation, then there's likelihood that they wouldn't even, they would maybe even sabotage the SHA in this implementation. So I would say in a big way, it's a bit political in a sense. But like you rightly mentioned, Joel, it's important that we actually make prioritization of these rural areas and public facilities for start. Because if we are putting private facility as our priority, that means like very soon we won't have working public facilities. And it's mostly the poor people who access these public facilities. So what are you doing to them? It would be a shame. Yeah. I don't know if that answers your question genuinely, but I think it's not just an SHA issue. It involves also the counties and the MOH. Yeah.
We've also gotten another. Thank you for that response, Zilper. We've also gotten another question from Zachary Kenyanjui, and his question is about the change in terms of funding technology, because NHIF technology had loopholes where some private healthcare providers had exaggerated the prices of their services, and he's inquiring if SHIF solves this specific issue. So maybe Robinson, can you take that?
Thanks a lot, Zachary. I think just speaking a little bit around the fraud that was being experienced with the NHIF system, I think to my knowledge is that over time, also NHIF previously, and of course, as we've seen through this presentation, NHIF began post-independence in, I think, 1965. So the lessons that NHIF has learned over time, and before, I think claims used to be processed manually. And I think with the advancement in technology, they introduced measures around trying to minimize or rather to prevent fraud, either from the providers making claims for services that have not been provided, as well as also ensuring that the beneficiaries do not defraud NHIF by either having people who are not within their beneficiary list to seek healthcare services, and then they're covered by NHIF. For example, I think the fingerprint identification and the notification that NHIF could receive whenever somebody went to seek care in a contracted provider. I think those are some of the mechanisms and measures that have been put in place with NHIF by NHIF over time to kind of try to minimize fraud. I think I wouldn't speak so much around whether the current SHIF and with the technology that they're trying to embrace, whether that will kind of solve this issue of loopholes within the system. But I think generally what I can say is that NHIF has also learned over time, and I think partly one of the things that I really struggle with is to reconcile why the government will spend so much money acquiring new system. Why don't we just leverage on what NHIF used to use and see where we could improve it? But I think my position is that even by the time we were transitioning from NHIF to SHIF, the issues of the fraud and, fraud from the provider or even from the beneficiaries, NHIF had done a pretty good job to try and minimize that. But as to whether SHIF is going to, reduce this further, I think I may not be able to give a direct response to that. Thanks, and over.
Thank you. Is there any other question? If not, any last remarks from you, Robinson or Zilper?
Thanks, Linnea. I think what I can say in conclusion is that I think our country is at an exciting stage. We may not immediately see the benefits or the disadvantages of the transition from NHIF to SHIF. I think it might take time, maybe 2 or 3 years into implementation, to actually have a good understanding. But all I can say is that I'm optimistic that perhaps it will be for the good. However, I would also, if for example, I was to, make the case to the president what he needs to do or not to do regarding health financing, you may have heard it said elsewhere that, actually UHC is it's a political decision, really. Is it that we prioritize health amongst other responsibilities and competing priorities for the government resources? So this is really a political decision, and then to that extent, then it just comes down to really, given our contextual reality of having a large informal sector, we can only do so much in terms of mobilizing sufficient revenue from the informal sector. Why, as a government, don't we just take the bold decision and prioritize health and at least attain some of the minimum indicators that have been recommended globally for a country that is keen on moving towards universal health coverage? So I think it's a nice space to watch as to how our health financing indicators are going to improve or change or remain the same over the next couple of years. Otherwise, thanks everyone for finding time to attend today's webinar. Thanks, and over.
Can I go, Linnea? Hello?
Hello, please go ahead.
Okay. So I don't know. I think we'll be speaking to a group of students who have an interest or people who have an interest in healthcare and health financing in general. And health is a very personal and is a very important thing. I mean, I normally say that, if we don't have money for education, we just be ignorant, but at least we'll not die, But if we don't have healthcare, people will die, So it's not something we want to delegate to experts or delegate to, NGOs we have to advocate for these issues. And so when discussions are happening around health financing, even if the understanding is not really up there, we still have to try and read. I don't know how many of you here have read the SHI Act, for example, because this is a big reform that is changing what we've known for the last 58 years. And, you know, in a way, would say that it's good the reform is happening because we didn't need to wait for another 58 years to just have 50% of coverage. So perhaps seeing the government is trying to make an effort should be lauded. However, the questions that are being raised in these processes means that the public, that is you and I, we still have to have our voices out there so that when discussions are being made, it's not that the MOH is having like closed-door meetings or counties are having their closed-door meetings. We also have to have our voices out there. So we can go through different associations, but also in our small spaces, whether it's on X Spaces or Twitter or wherever we, you know, find our information, we have to agitate and ensure that the information that is being passed out there, what is being discussed in terms of our health, this is our health, I think is taken into consideration. I think we all have, at least that's what I have. You know, almost in a month, I get a request for, you know, something to contribute. And even though I have no issue contributing, I know that it's the government's responsibility to ensure that people have access to healthcare. And so we need to push the government, because if we're taxpayers, then they owe us healthcare access. And so ensuring that even if you live in the rural areas, that your parents back in the village have access to healthcare. And I'm glad, this is a bit political, I'm glad to see what is happening when young Kenyans are going out there, the likes of Morara. Is it called Morara? I don't know. And, you know, checking what development projects are happening. We also need to go and check, are our facilities working? Because if the NHIF is going to only work with private facilities or the big facilities, they wouldn't know. So it's us to go out and see, like, do we have nurses here? Do we have medicine here? If not, we need to raise it. So, you know, ask our relatives back in the village to raise their voices. Otherwise, the government will think that everything is working well, and that's not the case. These are guys that if they fall sick, they'll go to Aga Khan, private to Aga Khan, remember, they'll fly to London. You know, we can't all afford that. So we have to stand up for our rights, and we have to be involved in these small discussions and debates. So I hope that from this discussion, the few things you might have learned here and there, you might go and read the Social Health Insurance Act and other acts. Maybe try to compare what the NHIF was offering and try to understand the discussions and debates, and also have your voice there, because your voice really does matter. Yeah, so that was political. Sorry, guys. But my PhD is on the political economy of health financing reform. So we can't run away from that fact, because health is extremely political. Robinson has mentioned that already. Thank you so much, Lina, for this opportunity to speak to young people and others who have an interest in this area. And I'm always so grateful to KEMRI. It's really, really amazing. Yeah, thanks.
Thank you so much. And right before we close, I'd like, I'm requesting if you can take a few minutes to answer the post-webinar survey that I've posted in the chat. We would really love to hear about your experience and what you'd like us to discuss in the upcoming webinars, and also what we can learn from this one moving forward. And yes, I'm looking forward to engaging with you in the future sessions again. Before I end this, as you guys are taking you're taking the survey, I'd give Kiptanui a chance to, because I can see his hand is up. So go on, Kiptanui.
Also, Anissa had a question on the chat. Yeah,
yes.
Go ahead.
Maybe you can answer Anissa's question before Kiptanui comes in. She was asking, how will the SHIF monitor its financial performance compared to NHIF?
Okay. Anissa, what do you mean by financial performance? Is it like the amount of money they're getting from premiums and how they're disbursing this to the facilities, or what do you mean? The disbursement. So from what the SHA, the new NHIF, so SHA is saying, at least in the act, is that they want to ensure transparency in the way the disbursements are happening. Of course, the challenges that have always existed has always been in terms of like delays in the disbursement to facilities, and also the fact that and they would say that the claims, the delays happen because some of the claims tend to be fraudulent, and so they need to find a way to assess and see that the claims are actually valid. And I guess that is why the SHA then decided that they're going to outsource claims management so that the third party is able to assess those claims before then they come to the SHA for payments. I think in this case, then they'd ensure that they don't make any claims that are not like supported by any documents. For example, I've had cases where somebody just had a sort of like, a small wound, and then they say that there was a whole, I don't know, brain surgery. And so you have to assess, like, can this facility really do brain surgery? Those kind of things. You can't do that because NHIF or SHA cannot be everywhere. So somebody has to be able to ascertain that. So I guess the claims management guys would be doing that kind of work. Of course, there are, of course, pros and cons to that. But I think these are small and steady steps, and I hope we can learn from the missteps that the government will be making, and I think improve from there. I do hope, and I think they're going to increase the money they're going to be making because 2.75%, that's a lot of money. So they're going to be making much more money. And so it's important for them to ensure there's transparency and accountability, not just to the government, but also but also to the public who are the contributors. You're asking if someone can be treated if the disbursement is delayed or is still being processed. Man, I don't know how. Robinson, do you want to check this?
Sorry, what? Question?
Can someone be treated if the disbursement from the NHIF or SHA is delayed or is still being processed?
That's a good question. So coming back to purchasing of healthcare services and the various purchasing arrangements. So depending on the purchasing arrangement in place, there are some that will incentivize the provider to over-provide services, and there are some that will incentivize the provider to, minimize their own costs. So under the, how would I'm asking because there's an emergency fund. So I think the way the SHIF arrangement is there is that, you first seek care from the primary care networks, then you are referred upward. And when you exhaust your, so to mean, for example, you can't access the emergency and critical, chronic and critical illness fund if you don't have the cover. As I understand SHIF, right? So basically, even if you're to seek healthcare services, you'd first start from the lower level, the primary care networks. You are referred upward through the system. So to answer your question directly, assuming a situation where the payment mechanism is capitation, we are giving X facility 900 shillings to provide care to these beneficiaries. If number one, the provider wants to minimize its costs, it has the incentive to refer upwards. We don't have this service here, we don't have medication here, they refer you upward for you to go and be treated elsewhere. But I mean, this is just a hypothetical answer that I'm giving. Really, I'm not giving it based on practice, because firstly, I'm not quite aware whether the implementation of SHIF has already kicked on. We're still between that window period, but I'm just trying to give a hypothetical answer. But yeah, so for instance, if you sought a care at a lower level facility and that facility is contracted by SHIF or by SHA rather to provide care, if the purchasing arrangement, depending on the